So thank you, Magnus, and it's a real pleasure for me to discuss this evening with you CRD analysis in food allergy, and particularly in peanut and nut allergy. So, dear colleagues, if we look at the diagnosis of food allergy from a clinician's point of view, we are confronted with up to 35% of self-perceived food allergy. We do measure specific IgE in up to 22% of the general population, but we assume that the prevalence of true food allergy is somewhere between 1 and 10%. So I think this slide clearly summarizes the difficulties we are confronted with if we want to do a diagnosis of food allergy, and it clearly indicates that we have to go and find new ways in the future to reliably assess our patients with a food allergy. What you see here are not yet published data from the UGES project on food allergy done, supported by the European Communion. And you see here one part of the study, which was a cross-sectional study, where we have recruited patients in all these greenly marked countries, more than 2,180 patients. 80% of those patients were over 14 years old. And you see here the hit list of the reported food allergies in these European countries, and this is really, the hit list is headed by hazelnut and apple, peanut and walnut. So peanut and tree nuts are among the most prevalently reported food allergies, at least in all the children and adults. Here you see a study from the United States investigating the distribution of childhood food allergy. And you see by an electronic survey. So they have included more than 38,000 children. And you see again here the hit list of reported food allergies in urban areas. And again, peanut and tree nuts are among the most prevalently reported food allergies here in children in the US. So we are well aware that we can get a sensitization to foods by different pathways. So on one side, we do have a sensitization to food over the gastrointestinal tract. We have a primary food allergy. And on the other side, we can have a secondary food allergy where we have a primary sensitization to inhalant allergens, mainly pollen, here mainly birch pollen, and mainly to the major birch pollen allergen BETW1, and then on the basis of cross-reactivity, a sensitization to plant foods. We are also well aware that the clinical severity of the clinical response is very different in the different patients. So on one end of the spectrum, we can have mild symptoms, such as, for instance, the oral contact urticaria, or also called oral allergy syndrome, where you see here these red patches, the swelling of the uvula, for instance, and these short living blisters at the oral mucosa. On the other side of the spectrum, we have life-threatening systemic reactions, such as laryngeal edema, asthma, and even the anaphylactic shock. What drives, however, the clinical severity from mild to severe, this question is not yet fully answered, but we know some exacerbating factors, such as, for instance, exercise, temperatures, intake of enzymes, and so on. And what we have become aware during the recent years is that the type of allergens to which a patient is sensitized to influences as well the severity of the clinical presentation. So what allergens can we expect to find in different plant foods? So for instance, in rosacea fruits such as apple or peach, we can find a PIR10 protein, a propylene, or a lipid transfer protein. In tree nuts, we find the same type of proteins, but in addition storage proteins, such as glycine, vicilin, or the 2S-albumin, and in addition oleosins. And the very same proteins or type of proteins or allergens we can find in peanut. So what you can recognize here, that these three types of proteins or allergens, the BETW1 homologs, the propylene, and the LTPs, are highly represented in the plant kingdom, and they are very cross-reactive. So what determines the allergenicity of a plant food protein? This question also is not yet fully answered, but we think there are different factors which influences the allergenicity, such as belonging to a certain protein family, being stable to processing and digestion, and whether an allergen occurs in high abundance or not. So you see here the three dominating allergen protein families. Here the prolamine family containing 2S-albumin, the lipid transfer protein, the cupine family containing these two storage proteins, and the storage protein and the lipid transfer protein, as already reported by Bob Hamilton, they are very stable to processing and digestion. However, the members of the BETW1 family are very labile. So we can easily imagine that a labile protein, which is degraded already by processing of the food and also under the influences of enzymes in the saliva and the gastrointestinal tract, they mainly can induce local oral symptoms. Stable proteins, however, can reach the circulation in an intact form and do have a higher potential to induce severe reactions. What about abundance of the allergens in food? So, for instance, here in apple, you see the BETW1 homolog MALDI1, and it occurs up to a concentration of 70 microgram per gram apple. Or the lipid transfer protein, again, up to 70 microgram per gram apple or skin, depending on the publication. On the other side, the storage proteins, for instance, RH2, the 2S-albumin, occurs up to 23 milligram per gram peanut. So we do have a 1,000-fold higher concentration of the storage protein per gram food than as for instance shown for these proteins. So taking all these informations together, we can say, yes, we do have this cross-reactive food allergy due to a primary sensitization to pollen mediated by propylene and BETW1 homologs. These proteins are labile and occur at low abundance, and they do have a lower potential to induce systemic reactions than the storage proteins inducing primary food sensitization, which are stable proteins and occur at high abundance. I already tried to tell you that these three proteins, propylene, BETW1 homologs, and lipid transfer proteins, are highly represented in the plant kingdom, and they are very cross-reactive. And therefore, we have a higher trend to observe for these proteins sensitizations which are not accompanied by a clinical allergy. And this trend is higher than we observe for the storage proteins. So let's go now into peanut allergy. A peanut allergy can be acquired over sensitization to stable allergens such as the storage proteins, Vicilin or H1, the 2S-albumins or H2 and 6, or glycinin or H3, then the lipid transfer protein here or H9. On the other side, a peanut allergy can be acquired over a primary sensitization to birch pollen, and here we have the BETW1 homolog RH8 and the propylene RH5. So RH8, 1, 2, 3, and 9 are commercially available for routine diagnosis nowadays. I would like to show you first some unpublished data from the EuroPreval project. We have included here 95 patients with a history of a peanut allergy. 40 had an anaphylactic reaction. The other ones underwent double-blind placebo-controlled food challenges. 29 were positive and 26 negative, so they were tolerant. Here you see the sensitization pattern of these patients. So first of all, the sensitivity of IgE measurement to peanut extract in our population was 77%. So if we would restrict our in vitro investigation to the determination of IgE to peanut extract, we would miss here a part of our patient with a true peanut allergy. So the major allergen in our patient were RH2. If we considered all components, as you see here, the sensitivity went up to 90%. So we can conclude as a first fact, component resolved diagnosis increases the sensitivity of in vitro diagnosis. 20% of our patients had local reactions at the oral mucosa and 80% had a systemic reaction. So what we observed was that IgE to RH2, this storage protein, of at least 1 kilounits per liter was significantly associated with the occurrence of a systemic reaction. Here you see the sensitization in our tolerant patients. Those patients were sensitized to RH8, 9, so the BET1 homolog, the lipid transfer protein, and the profilin. None of our tolerant patients were sensitized to storage proteins. So this is what I tried to explain you with this picture. So if we have IgE to these three proteins, profilin, BET1 homologs, and lipid transfer proteins, we have a higher trend to observe sensitization, which is not accompanied by a clinical reaction. Again, summarized in that study, other studies have slightly different results. Sensitization to the storage protein was accompanied in 100% by clinical reactivity. Sensitization to RH8, the BET1 homologous protein, or the lipid transfer protein, was accompanied by a clinical reactivity in 40 to 60%. So these are the conclusions of the Europreval project study on peanut. Patients with sensitization to storage proteins are likely to show allergic reactions to peanut, and sensitization to RH2 of at least 1 kilounits per liter was significantly associated with a systemic reaction. So let's have a look to other studies in peanut allergy. Here you see a study published by Ann Azonoy from Sweden. Here 200 children from the so-called BAMSI cohort. BAMSI is the, as I learned, is the Swedish or is the world's most strongest bear, and it's a comic which is very fashionable in Sweden. So 200 children were included with or without sensitization to birch pollen or peanut. So they identified 46 patients being sensitized to the storage proteins RH1, 2, and 3, and 23 patients being sensitized to RH8 but not to the storage proteins. And they observed similar data as we did in the Europreval project. So here, the patients with a sensitization to storage proteins were clinically reactive, so they had a true peanut allergy in up to almost 90%. Patients being sensitized to the BET1 homologous protein, RH8, were clinically reactive in less than 20%. Here you see data from the UK, again in 8-year-old children. So these authors observed in their cohort of more than 1,000 children that at the age of 8, these children were sensitized to peanut extract in 12%. So 12% of these British children have IgE to peanut extract, but not all are allergic, obviously. So they selected 29 patients with IgE to peanut extract and an allergy to peanut on one side, and 52 patients with IgE to peanut extract but who tolerated peanut. Then they determined IgE to the different peanut components, and they looked whether they could identify a component which could differentiate between these two clinical settings: sensitization with allergy, sensitization by tolerance. So you shouldn't get frightened about this figure, but it's quite easily to read. So if a curve goes through this upper left edge, this would be a perfect tool to differentiate between these two different clinical settings. And they observed or identified an almost perfect component, which was RH2. So RH2, or sensitization to RH2, was 96% specific for a peanut allergy in this study, and IgE of at least 0.55 kilounits per liter was 100% specific for a peanut allergy. So many different studies have been done on CRD in peanut allergy in different populations. So in France, Gondrianu and colleagues, in Denmark, Eller and colleagues, then in the US and Sweden, Lieberman and colleagues, and in Australia, Deng and colleagues. And all those studies just show the same. IgE to RH2 is highly specific for a peanut allergy. So in that study, for instance, IgE to RH2 of at least 1.6 kilounits per liter was 100% specific for a peanut allergy, and in the Australian study, this value was 3.5 kilounits. So let's have a closer look to this Deng study from Australia. They have included really young children, aged 11 to 15 months from the health nut study, and they identified 100 patients with a peanut allergy, so a positive food challenge and a positive skin test to peanut extract. And they identified 100 peanut tolerant controls with a negative food challenge. Part of them were sensitized to peanut extract. So they calculated a cutoff level which was 95%, with a 95% positive predictive value, and this was 15 kilounits per liter. And this has been also published from other authors. So if they took this cutoff level, then instead of 200 provocations, they only needed to do 95 challenges, with a false positive rate of 2% and a false negative rate of 9%. Then they calculated the cutoff level for RH2, which was 98% specific for a peanut allergy, which was 1.19 or 97% for 1 kilounits per liter. So if they took this cutoff level of 1 kilounits per liter, they only would have to do 44 challenges, again with a false positive rate of 3% and a false negative rate of 5%. So by combining this approach, doing first IgE to the peanut extract and then to RH2, and only doing challenges in the one which are below the cutoff levels, they could significantly reduce food challenges by over 60%. So a similar approach has been done by Lieberman and colleagues. They have included 167 children at the median age of 11 years from the US and from Sweden. So 63% of those children had a positive food challenge with peanut. So again, look here, the cutoff level of 15 kilounits per liter IgE to peanut extract. 90% of those patients had a positive challenge, but 9% had a negative challenge. So let's have a closer look through these patients. So IgE to peanut extract over 15 kilounits per liter, and you see these three patients were RH2 negative. All the ones who had IgE over 15 kilounits per liter to peanut extract and were sensitized to RH2 were positive under challenge. So we can conclude that if we have patients with IgE to peanut extract over 15 kilounits per liter and they do not have IgE to RH2, these children need to undergo challenge. So let's make it slightly simpler. So if we have IG to peanut extract, whether the value is above or below 15 kilunits per liter, and the patient has no IG to RH2, these children should undergo challenge. If we have patients with IgE to peanut extract above this threshold level of 15 kilunits per liter, and the patient is sensitized to RH2, these patients are very likely that they would respond under challenge, so we do not need to do challenges in those patients. If the patient has IG to peanut extract below this 15 kilunits per liter, and the patient are sensitized to RH2, I think here we still have to make a question mark. In the Europreval patients, but we included adults mainly, all those patients were indeed peanut allergic. In the Dunk study or in the Lieberman study, a subset of those patients still were not reactive. So I think in the future we need to define cut-off levels which indicates whether we should do in this situation challenges or not. So let's summarize the CRD analysis in peanut allergy. You see, if a patient does have a sensitization to the beta-1 homolog RH8 or to the lipid transfer protein, here we need to do challenges because we are not sure whether these patients are indeed peanut allergic or not. If the patient is sensitized to the storage protein, the likelihood that the patient is indeed food allergic to peanut is much higher. And if as we have showed it for RH2, at a certain level, sensitization to RH2 has a higher risk to induce systemic reactions than the other proteins. So let's have a short look to tree nut allergy and here to hazelnut allergy. It's again the same. A hazelnut allergy can be acquired over primary sensitization to stable allergens. Here the storage proteins, CoRe9, which is a glycinin, CoRe11, a vicillin, and CoRe14, 2S-albumin. Then we have the lipid transfer protein, CoRe8. And on the other side, hazelnut allergy can be acquired over a primary sensitization to birch pollen. Here we have the beta-1 homolog, CoRe1, and the profilin CoRe2. So a few years ago, we have done a study in Europe, including patients from birch pollen exposed regions, here from Denmark and Switzerland, and from birch pollen free region, the Madrid area. So patients from the birch pollen exposed countries here, as we expected, were mainly sensitized to the beta-1 homologous protein hazelnut CoRe1. And again, as expected, 90% of those patients had mild symptoms restricted to their oral cavity. However, the Spanish patients from the birch pollen-free region of Europe were sensitized in 70% to the lipid transfer protein CoRe8, and more than 40% of those patients had a systemic reaction. So we can say here, if a patient is sensitized to the lipid transfer protein in hazelnut, he has a higher risk to have a systemic reaction upon hazelnut ingestion than if he is just sensitized to the beta-1 homologous protein. Now again, some unpublished data from the Europreval project. We have included more than 730 hazelnut allergic patients into this project, and in more than 420 patients we could do CRD analysis. This has been done by Marinda Tima from Amsterdam Medical Center, and you see the sensitization pattern. So the major part of our patients were sensitized to the beta-1 homologous protein, CoRe1, but subsets of patients recognized the other allergens too. So 16% of our patients had a severe reaction upon hazelnut ingestion with respiratory or cardiovascular symptoms. 36% a moderate reaction with gastrointestinal symptoms or skin symptoms, and 46% a mild reaction restricted to the oral cavity. Maureen has now compared the severity of the clinical reaction and the sensitization pattern, and she looked whether there would be a component which is associated with a severe reaction to hazelnut. And indeed, she identified two components here, CoRe9, the glycine from hazelnut, and CoRe14, the 2S-albumin, which have been associated with severe reaction with odds ratio of 2.9 and 4.7. So similar data have been published by Masthoff and colleagues. They've included 160 patients, 80 children, and 80 adults. 40 in each group had no reactions to hazelnut or mild symptoms, such as an oral allergy syndrome. The other 40 had objective symptoms upon hazelnut ingestion, such as urticaria, angioedema, emesis, diarrhea, street or wheezing, and so on. So what they observed here is that patients with objective symptoms were more frequently sensitized to these two storage proteins, CoRe9 and CoRe14, than patients with mild symptoms or no reactions. So you are now able to read such a figure. So in children, they could see that the sensitization to CoRe9 and CoRe14 had a good potential to differentiate between these two clinical settings, being sensitized to hazelnut but having mild or no symptoms, or being sensitized to hazelnut and having severe symptoms or objective symptoms. And here are the data. So IgE to CoRe9 was 95% specific for a hazelnut allergy with objective symptoms in adults, over 1 kilunit per liter in children. IgE to CoRe14 was 95% specific, again, for having an objective reaction to hazelnut in adults, and over 5 kilunits per liter, this figure was 98%. So we can conclude from both studies that patients with sensitization to hazelnut storage proteins, CoRe9 and CoRe14, have an increased risk to develop allergic reaction to hazelnut and develop more severe reactions. So we can add now these two components here. These components are associated with an increased risk for a systemic reaction. So I think we shouldn't fish in the future any longer only in such muddy water called food extracts. So it's much nicer to identify the single fishes, the components. So I think I could show you that by applying CRD approaches that we can improve our in vitro diagnosis, particularly in terms of sensitivity, but also by correlating the sensitization to single allergens with the clinical response, we can identify risk markers. And I showed you these three risk markers are H2 from peanut and CoRe9 and CoRe14 from hazelnut. And with this, I would like to acknowledge all partners from the Europe project, and I thank you very much for your attention.